Hey everyone, I'm Dr. Rabah Sibe, Associate Program Director at San Joaquin General Hospital Family Medicine Residency Program and new Physician Director here at California Academy of Family Physicians. And we know that addiction medicine is family medicine. Did you know that only 1 in 5 people with opioid use disorder receive treatment? We'd like to change those odds. In our latest series, we bring you stories of doctors and their patients who have worked together to reduce the harm done by opioid use disorder. These brief stories will bring you into the hearts and the minds of our guests. We hope that this will inspire you to do everything in your power to bring medical attention to the opioid use disorder patients in your practice. Hey Tipu, say it ain't so, my friend. It's really hard to believe that this is our last episode in our incredible series, 1 in 5, Increasing the Odds for OUD Patients.
Rob, it was a lot of fun and it's gone by really fast. And I hope our listeners are really able to glean some of those big picture items that are really important in us being able to write that first prescription and really make a change in our patients' lives and potentially save their lives with what we've heard in this series.
Yeah, I agree. I mean, in this series, we went from talking with legends, and I mean legends. We've met patients where they are. We're breaking down stigma. We're trying to get to write that first prescription. So we're really excited to hear this last one. I hope it's a really good one. So tell us a little bit more about what we're going to hear today.
Yeah, today we're going to speak with Dr. Anusha Chandrakanthan, and she's got a very interesting background, having worked in telemedicine with substance use disorders and now working with the homeless and those that are marginalized. So she really understands the difficulties in managing this population and some of the barriers that we face. So we're going to even take it a step back. 20,000 feet, bread and butter. What are some of the important aspects we need to take home in how we manage these patients in our practice?
I can't wait to hear it. But I do want to give a huge shout out to you, Tipu. Appreciate you. Thanks for doing this series. It's been an absolute pleasure to hear from you and all of these physicians working with MOUD. Hope you guys continue doing the good work and we'll get more listeners to start doing the same.
Thanks, Rob. It's been a great series and I've enjoyed working with you and Josh and Lori and Jerry. And all I can say is, Joe Rogan, watch out. Here we come. Hi, my name is Tipu Khan. I'm a family physician and an addiction specialist, and I'm excited to talk to Anusha today. Anusha, can you start off by just telling me a little bit about yourself?
Sure. Thanks for having me. My name is Anusha Chandrakanthan. I am a family doc and a board-certified addiction medicine specialist. I work with the homeless program in Santa Clara County, and I also work at the dual diagnosis clinic at Stanford School of Medicine, doing fellowship training for the addiction medicine fellowship program.
Wonderful. So tell me a little bit more about your addiction medicine experience.
I did my residency in West Virginia, and I'm a foreign medical graduate and moved from India to West Virginia. So a lot of my training in primary care, now looking back at it, involves substances and methamphetamine and opioid use and chronic pain. After training, I moved to California and I worked in the Central Valley. And as we all know, there's such a steep learning curve in the first year of the practice of medicine as a new resident and then an attending that it was really overwhelming when I realized that I somehow didn't have the skills to treat people with substance use disorders. And then I went ahead and I did a little bit digging and research and realized that, okay, this is something that maybe I should learn more about. And back in the day, we got our X license at that time. And then I said, oh, what do I do with buprenorphine now? And then I learned about these resources such as Echo Project and things like that, and utilized those sources to start implementing that in my practice just a little bit. I went ahead and did a fellowship just so I can arm myself with a little bit more knowledge about the language of addiction and how I can improve access to patients who are struggling with the substance use disorder and how I can make it a part of my practice. But what I did know is that I still wanted to do primary care, and I didn't want to be a part of the siloed addiction medicine practice because addiction medicine and primary care fit so well together that they just belong. And as I saw my diabetics and high blood pressure patients and uncontrolled hypertension and the people who had endocarditis, I said, okay, this is where I belong, doing both of that together. And that's how I found my job right now, which is doing homeless healthcare in the county.
Wonderful. Thank you. Can you walk me through a typical patient you see in the job and the position you're in now as both a family physician, primary care doc first, and as an addiction trained physician?
A lot of times what we see is people coming to see us with a very clear-cut substance use disorder. So they're telling me that, oh, I'm using fentanyl, I'm injecting heroin, and now most of the time we only hear fentanyl. So I am using methamphetamine and I need some help, I need some support. And what I'm doing is I'm writing a prescription for buprenorphine at that point. I've gone away from using terminology such as induction into buprenorphine because I've spoken to people about this. I've realized like it amplifies the fear around buprenorphine using big terminology. So I say, okay, I'm going to start you on buprenorphine today. What does that look like for you? Have you been on buprenorphine before? Have you been on any other forms of medication-assisted treatment before? And how has that journey been for you? It is so amazing and surprising what patients can tell us by just asking these questions. And a lot of times patients will tell me like, yeah, I was using fentanyl and I just couldn't get any more. And I used some bupe on the street. And this is how I felt. This is the dose that worked for me. And that's where I start people on. I really listen to what they're telling me and sometimes use that as their starting dose and sometimes just take their experience into the shared decision making.
So it's evident that you find this job really rewarding. Anusha, can you tell me, for a primary care physician who may have not had specialty training and maybe didn't get this experience in residency, how difficult is this for you to incorporate into your practice if this is a new skill set? Is this a difficult challenge for a busy primary care doc to start doing within their practice? Is this something that's doable? What are your thoughts?
I think as primary care doctors, we are in this really unique position of thriving in chaos and thriving in trying new things and learning new things. And we treat patients holistically. So we provide full organ, full system care for our patients. And what's really interesting is that substance use disorders is just like any other chronic medical illness. So it touches every single part of our body that diabetes, high blood pressure does. So in learning something new, it can be overwhelming, and that's why there are all these resources out there, such as PCSS or the National Clinicians Hotline and the ECHO Project. So there are resources out there if people have this fear of starting people on buprenorphine. However, it's not that hard after you have done a few. And after you get the patient from the emergency room who was started on buprenorphine and rewriting that script and them coming back to us and telling that, hey, like kind of saved my life. I lived because you gave me that script for buprenorphine. And that's really exciting to hear. That is such a unique position of privilege that we sit in as family docs, to be able to listen to the stories of success of patients who are now in recovery.
So, Anusha, one of the questions we get a lot from new physicians that are trying to use buprenorphine in their practice is, how do I do this without running into this dreaded precipitated withdrawal if I'm starting buprenorphine on someone who's using fentanyl? But there's so many patients that are out there in the community that just need refills. They just need to be stabilized with a trustable primary care physician they can see regularly for all their primary care needs, but also under that same roof, get their substance use disorder needs met. What are your thoughts on having primary care see more of these patients, even those that are stable, just for refills?
A lot of times, what it is asking the question of, hey, how are you doing on this dose? I see they started you on 8 milligrams 3 times a day. Are you feeling okay? Are you having side effects? Are you having any cravings? And it's really important to also ask about, have you had any relapses on this dose? Because what we do know is relapses are a common part of any chronic medical illness, and especially addiction. There are a lot of factors that drive that, whether it's psychosocial stressors, whether it's their mental health that needs treatment, and just being able to support them. Buprenorphine, as we know, it saves lives, as does methadone. And all it is about is being able to talk to the patient and be like, yeah, I'll refill this for you. I'll also give you some Narcan and we'll see you next week or next month. I think a lot of my own practice has shifted from doing monthly scripts to now monthly scripts with a refill on it, just so that we, one, have patients come back, open up spots for other folks to be seen as well, and support patients in their life. Because as patients are more stable in their recovery, now they have jobs, now they have families, they're taking care of their kids. And these are things that didn't happen before for them. So if I can support them in any way, I would.
Anusha, you're making this sound pretty doable and pretty easy, actually. It sounds like what I do in my practice all day long, right? I see patients for diabetes or high blood pressure, and I'll write them for 30-day prescription with a couple of refills or a 90-day prescription with a couple of refills. So you're saying that you feel comfortable refilling some of these medications for opiate use disorder, such as buprenorphine. When you do that, how do we make sure these patients are safe and that they're following up, or do we need to? Where have we come today in the state of buprenorphine safety and efficacy in the primary care setting?
When I have patients come in and they've been stable for a while, say 6 months, and they're telling me that they have a bunch of things going on in their lives that require their time and effort, a 40-hour work week where they are using that money to pay their rent, I'll go ahead and do that fill. A lot of our patients are so stable on buprenorphine that it's so much better than what they would do out on the street without buprenorphine. So if you ask anybody to compare their lives on MOUD versus what it was before they were on MOUD, it's such a huge difference. And they will tell you that it's had such a positive impact on their life and their relationships that it's really the reason that they're living today. So in that context, yes, I would do that refill, right? I wouldn't cut anybody off their insulin. I would do sometimes a year's worth of blood pressure medicine. So I feel so comfortable doing that. Of course, when you're seeing the person, do the toxicology screen if it's indicated, do the cures review, and do all the stuff that we're supposed to do while prescribing a controlled substance, but also take into account the patient's life.
Anusha, so what about the patient that you're seeing in your primary care practice that's been stable on buprenorphine, but now they come to you and they tell you that, hey, I'm smoking heroin or I'm smoking fentanyl again. What do you do in that situation with their buprenorphine prescription or the clinical management from a primary care setting?
A lot of times I'll tell people and normalize that this is firstly just the course of addiction and this happens. And this doesn't mean that I'm going to stop their buprenorphine. It doesn't mean that they're going to have a punitive effect to them disclosing something. It's also really important to understand the cycle of shame and guilt that's associated with addiction. And when patients actually show up in our clinic and tell us that, hey, I'm still using, there is so much shame and guilt to that cycle that them just being there and present and being honest with us is so unique and so powerful. And I think that's really the value of that patient-physician relationship. And it shows that it's a safe space for them to come and talk to us about it. A general analogy that I would use is, say, if you had a patient who had COPD, we talk to them about nicotine replacement therapy as a part of their general care plan of smoking cessation. COPD has symptoms such as cough and shortness of breath. Substance use disorders has symptoms such as a craving, and all we're doing is treating that craving with MOUD. Just the same way we would treat smoking cessation with nicotine replacement therapy, and smoking cessation is nothing but nicotine use disorder. So I think like primary care physicians are also like already treating substance use disorders to some extent. And it's not just about fentanyl, it's also about alcohol, smoking. We talk to our teens and adolescents about marijuana and vaping all the time as well. So I think we're already doing a lot of the work. It's just about continuing to do it, continuing to be an advocate for these patients, and also continuing to encourage our peers to do it and being that point person where people can come in and ask us a question and we can support them. That's how it spreads.
Yeah, you're totally right. I agree with you 100%, Anusha. And I think it starts from the ground up, right? It really is a grassroots movement, and we need to do a better job in medical school and training our colleagues on what opiate use disorder is, how you treat it, et cetera. Especially since the X waiver has been removed, this is something everyone should be prescribing. I am proud to say that CAFP does a pretty good job at this, and this is the third iteration of the California Residency Program Collaborative, in which they work with residencies and training them on substance use disorder management. So I think we're getting there. But any tips, advice, or thoughts you have for those that are currently in training or freshly out of training and want to start using buprenorphine in their practice?
Utilizing the resources that are available is a great first step. There is PCSS out there. There's the National Clinician Call Line. There's the ECHO Project again. So utilizing the resources for some of those complex starts for patients who have co-occurring disorders, who are using like high-dose benzodiazepines, because a lot of times in our practice nowadays, we're seeing poly substance use more often than not. So using these resources is a great first step. And the other thing I always tell my own colleagues is having that conversation in a non-judgmental manner with our patients is maybe the best way to start, because once patients know that it's a place that they can come to where they can talk about their addiction and get treatment, that patient's coming back. The patient might come back like a month later, maybe 6 months later, they'll come back for sure.
Anusha, this all sounds great, but I'm a busy family physician. I'm working in FQHC. I've got 12 patients every half day. I don't have time to pick up a new skill set. Why can't I just send them to you? Why should I do this when I've got a busy practice already ahead of me? What am I going to get out of it?
This reminds me of a patient that I had who is still a patient of ours. She was unhoused using methamphetamine as well as opioids. And we started her on buprenorphine. She was living in her car, had 3 kids, and we know that the system can be really punitive. So she had lost her kids to CPS and was not in contact with her kids for a while. About 6 months into her being on buprenorphine, she had an ongoing case for which we wrote some letters for her, supporting her recovery, saying she was engaged in treatment. And we've been seeing her for about 5-6 years now. So as of today, she has her kids back. She is housed. She has formed connections back again with her partner, her mom. Her grandmom paid for her to have dental work done recently. And she came to us, and when we look at her now and we talk to her now, there's such a shift in how far she's come. And I think that is the most rewarding thing about doing addiction medicine plus primary care. We take care of her kids. We're primary care home for all of them. And just kind of seeing this is really rewarding. The other thing about addiction is it can be so generational, and breaking that cycle and being a part of that is a privilege as a primary care doc. And I will always be grateful for these experiences that ground us and motivate us to continue doing the work that we do.
So Anusha, you mentioned a couple of resources out there like the PCSS, ECHO, National Clinicians Hotline. There's also the UCF Warm Line, all wonderful resources for writing that first prescription or even walking you through a difficult prescription when you need to get some support. Just a quick plug, remember the California Academy of Family Physicians has a MOUD Champion peer support network. So you can hop on to our website and request a peer support that can, again, be there to walk you through those first couple of prescriptions. And that's available at familydocs.org/SUD, familydocs.org/SUD. Anusha, thanks for taking the time to talk with us. Any last thoughts or remarks you wanted to share?
Addiction and substance use disorders are and historically have been diseases of isolation. And treating these disorders empowers our patients with connection. It empowers us with connection. I look at connection in the form of capitalizing what we already have with our patients, that connection, fostering new connections for our patients within the community, rebuilding that for patients with their own family members and the joy that they get out of it. And I've really just come to look at addiction medicine as connection.
It's interesting. You touched on a lot of great topics, and you really touched today on the family unit of what you're trying to do and avoid generational trauma. Choosing to treat opiate use disorder isn't just another skill set in your repertoire. It really is trying to be the physician you wrote about in your personal statement. It's being that family physician that we all want to be and that we modeled and are trying to model to our communities. It's about celebrating the triumphs, but also the difficulties that patients face in navigating this chronic, relapsing, remitting disease. So in my eyes, addiction medicine really is just good family medicine, and you're doing that every day out there, Anusha. Thank you so much for doing that, and thank you for taking the time to share your wonderful story with us.
Thank you so much for having me.
Thank you so much, Dr. Chandrakanthan, for sharing your story with us. I hope that her experience moves every one of you to explore offering MOUD in your setting. And if you aren't already there, listen to this series and the first series, and then listen to it again. If you enjoy our show, please rate and review us on Apple Podcasts or wherever you get your podcasts from. Until we meet again, this is your favorite family doc, Dr. Rabah Sibe. This podcast was created, produced, and recorded by the California Academy of Family Physicians. The Family Docs podcast series 1 in 5, Increasing the Odds for OUD Patients, is supported by the California Department of Healthcare Services. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent or the California Academy of Family Physicians.